Hello, my name is Stephan Landis, and I am from the Department of Hospital Medicine and Ambulatory Wound Clinic at the Guelph General Hospital in Guelph, Ontario, Canada. My topic today is going to be debridement strategies assessing and managing wound bioburden using MolecuLight IX imaging. Now, venous ulcers are very common in clinical practice, particularly in the ambulatory setting, and they are frequent problems that are referred to the clinic for consultation. The healing profiles of venous ulcers are influenced by a number of things, as you can see here on the slide: the wound duration, moisture balance, bacterial involvement, antisepsis and compression, and of course, the frequency of sharp debridement. In this particular study, we're going to be using MolecuLight IX, which is a handheld optical imaging device using autofluorescence. This device actually permits rapid, real-time means to detect bacterial distribution in venous ulcers. You can see here what autofluorescence looks like for Staphylococcus and streptococcal organisms, which fluoresce red, while Pseudomonas aeruginosa fluoresces green or cyan. And this difference in color is really quite easy to detect with the device. Now, Pseudomonas aeruginosa, or Pseudomonas species, frequently produce robust biofilms, as you can see on the left side, which represents an established biofilm, which can in fact stall wound healing. On the right side, you see a clinical specimen using MolecuLight, and you can see the green cyan autofluorescence on the ulcer, and you can actually see the pyocyan or pyocyanin on the dressing itself, which has actually come off this particular ulcer. So the aim of this particular study was to establish the efficacy and pattern of sharp debridement, pre and post debridement in chronic venous ulcers with and without Pseudomonas aeruginosa involvement. And you can see here in the picture what a pre-debridement ulcer photo looks like and compare it with a post-debridement setting. So what did we do? We used at the bedside real-time optical imaging using MolecuLight to evaluate venous ulcer autofluorescence pre and post-debridement. Wound cultures were also taken using the Levine technique to identify and confirm wound flora. So in the pre-debridement setting or assessment, what we see is a categorization of autofluorescence. Some ulcers have no autofluorescence pre-debridement. Others may have a light degree of autofluorescence, some discrete and some confluent. And you can see the progression in the red section of increasing bacterial involvement in different wounds, and you can see an increase in cyanin from left to right in the same fashion. In the post-debridement assessment, we determine whether there is autofluorescence left after debridement, whether it is reduced, whether it is unchanged, or whether there is in fact increased autofluorescence post-debridement. An example here would be pre- and post-debridement fluorescence with Pseudomonas aeruginosa, where on the left side you see an ulcer which has a great deal of confluent pyocyan, and on the right side, post-debridement, almost complete resolution of the island of pyocyan present. In the same vein, when we look at pre- and post-debridement autofluorescence with non-Pseudomonas organisms, we can see a confluent field on the left and a marked reduction in autofluorescence after wound debridement. So in this particular study, we looked at 42 patients, which actually had a predominance of women, which is not surprising in a clinical setting. 208 chronic venous ulcers were followed for approximately 7.8 months, with roughly an average of just under 5 ulcer visits per patient. Interestingly enough, 22% of this caseload really showed no autofluorescence at the outset. So when we looked at the results pre and post debridement of those who had Pseudomonas aeruginosa or non-Pseudomonas aeruginosa, we see the following results. And I would draw your attention to the numbers at the bottom. We can see out of a population of 89 ulcers which had red fluorescence, that 46 had a reduction post-debridement, 31 had no change, and interestingly enough, 12 showed increased autofluorescence post-debridement. On the other side, with Pseudomonas, we see 46 having a reduction in autofluorescence, 27 unchanged, and only 1 actually showed increased degree of fluorescence post-debridement. So when we summarize this, what we notice is that Pseudomonas aeruginosa occurred in about 74 out of 208, or 36% of chronic venous ulcers, and this was confirmed by culture. Post-debridement, reduction in autofluorescence, we can see 52% in the non-Pseudomonas category showed reduction, and 62% of the Pseudomonas group showed reduction, which gives us a measure of the efficacy of sharp debridement. Even in expert hands, sharp debridement reduces bacterial load to the tune of approximately 50 to 60%. Interestingly enough, post-debridement, there was a significant difference in terms of the patterns of Pseudomonas and non-Pseudomonas involvement. Only 2% of those wounds that had Pseudomonas identified by autofluorescence and culture showed increased presence post-debridement, while 21% of the non-Pseudomonas ulcers showed increased degree of autofluorescence. This is both clinically and statistically significant, which is essentially a measure of tissue level involvement. Basically what this says is that Pseudomonas seems to be present less often in deeper tissue levels compared to non-Pseudomonas organisms. So in conclusion, what can we say? We can say that the efficacy of sharp debridement in chronic venous ulcers in expert hands ranges between 50 and 60%. It is not 100%. And increased autofluorescence post-debridement confirms that the red flora, or the red autofluorescence, exists at multiple levels, while the Pseudomonas or cyan autofluorescence occupies a more superficial location. Hence, one might say that Pseudomonas aeruginosa is probably less likely to cause deep compartment involvement or infection because of its reduced presence in deeper wound locations. This actually makes clinical sense because this is what we indeed observe in real time at the bedside. And this would have implications in antibiotic usage and stewardship. One might argue that the presence of Pseudomonas in a wound requires good debridement and the use of dilute topical vinegar or acetic acid as a primary management strategy rather than putting patients on systemic antibiotics. Thank you.